everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to spend some time with us. And we have, I think, a fascinating topic to explore today with some possible other offshoots. I want to welcome my co-moderators, Dr. Jocelyn Hines, Dr. Ivan Waltz, and let you know that Dr. Maxey, our founder, is fine. He just was not able to make it in time for the show today. But be that as it may, hold on to your seats because I think we're going to have an exciting talk. Our speaker is someone that we have welcomed before, Dr. Renee Bovell. I think you'll recognize her when on her window there. I'm really excited about Dr. Bovell because ophthalmology is one of those specialties that, as you can imagine, wasn't one of the easiest subspecialties for Black folks to get into. And she has not only gotten into it, but she has mastered it. She is not only board certified in ophthalmology, an academician, an author, but she also recognized the times that we were in and went out and got another degree in cybersecurity strategy and information management, something that not many of us have, but probably at some point or another will wish that we did. So without further ado, Dr. Bovell is going to talk with us about something that she feels very strongly about, and that is vascular eye disease. Dr. Bovell.
Thank you, Dr. Nabert Stevens, for that lovely introduction. I appreciate it. We have a lot to get through, so I'm going to share my screen and get right into it. Let's see here. Here we go. Alrighty. So today we're going to talk about vascular disorders of the retina. And the reason why I feel that's such an important topic, especially for people of African descent, is that these problems such as high blood pressure and diabetes greatly affect us. And sometimes they're almost like silent diseases until it becomes too late. So I just want to educate you on some of the things that you can kind of tune into, pay attention with your vision, and know when to go and see an ophthalmologist. First, I like to start with the anatomy of the eye. This is the cornea. The cornea is the part of the eye that people touch when they put on contact lenses. Then there's a hollow space, and then there's the iris. The iris is the part of the eye that gives the eye its color: brown, green, blue, etc. Behind the iris is the lens. The lens helps us to focus. So it goes into a little ball when we try to read. And little kids can read up close like that. And as time passes, we can't do that, and we need help with reading glasses. Then there's the area here. This is a hollow, it's hollow. The eyeball is a hollow ball, and it's filled with a jelly-like substance called the vitreous. And lining the eye is the retina. And the retina is sort of like a layered lasagna of cells. And interspersed throughout those cells are blood vessels and nerves. And those coalesce to form the optic nerve, which transmits those impulses to the brain so we can interpret what we're seeing. This is just what I just said. The retina is a thin, semi-transparent, multi-layered, light-sensitive neural tissue that lines the inner eyeball. And as light is focused, that light is then transmitted, the impulses are transmitted to the brain via the optic nerve. And the macula is the most sensitive part of the retina. It's in the center, and that's what allows us to see our central vision, faces, reading, etc. So we're going to talk about these 4 disorders of the retina. Let's start with diabetic retinopathy, which is a disorder of retinal vessels that eventually develops to some degree pretty much in everyone who has long-standing diabetes. That's whether it's type 1 or type 2. And the reason why this is so important is because it's the most common cause of having both eyes having severe visual loss in people who are of working age. And, you know, sometimes we've been conditioned to think, oh, my grandmother had diabetes, my mother had diabetes, now I'm going to get diabetes, but it's not necessarily true. Diabetes, we can modify our environment and what we put into our bodies and what we do, and that may help put it off, stave it off for a while. So what are the risk factors? Well, if you have it earlier, at an earlier age, that's a problem. If your diabetes is poorly controlled, if you have a history of diabetes when you're pregnant, or if your mother did, if you have a double whammy, high blood pressure and diabetes, if you have kidney problems or cholesterol problems, if you're obese, if you have anemia, and please, if you smoke. I know some people think it's okay to smoke, but I tell my patients, no matter what they come in for, I'm going to do my best to help them stop smoking. And because sight is one of our most precious senses, please don't, I tell my patients, don't pay somebody to help you become sick. That's what we're doing. We're paying the tobacco companies to help us become sick. So don't pay someone to help you lose your vision. So what are some of the symptoms? Well, you may notice a sudden increase in eyes and floaters. And these are the normal floaters that are associated with aging. Like you may see a spider occasionally, it looks like a spider or a gnat, and you wave it away. These look like black rain, or like you're looking through a cobweb or a spider web. Your vision may become blurred. You may even develop sudden loss of vision in one eye. You may suddenly start noticing halos around lights. In addition, you may have problems with flashing lights or poor night vision. Okay, so this is what a healthy retina looks like. This is the optic nerve. This is looking face on. So this is what your ophthalmologist sees when he or she looks at your eye. And these are the pictures that we take. So this is the optic nerve. This is a healthy optic nerve. They have a nice small cup here. This dark area here is the macula. So we want to keep this area pristine. I like to say the retina is sort of like, if those of you can remember when we used to have the Kodak film and we'd have to load it in the camera, and we wanted to keep that film pristine. Well, that is the same with the retina. We don't want any scratches, sand, anything like that, like what we did with our cameras. And you can see this retina has some blotches on it. We'll go into that further, but this is what a healthy retina looks like. So we divide diabetic retinopathy into proliferative and non-proliferative. Well, what does that mean? Non-proliferative means that you are not making new blood vessels. The diabetes has not progressed to the point where you're making new blood vessels. If it progresses, we call it proliferative diabetic retinopathy, and that means you do have new blood vessels, and we're going to go over that. What I want to show you is that this disease can be kind of very insidious and sneaky. You can look right there. There's one little dot there, and I bet if I didn't point that out to you, you might not even notice that. So it's very, very mild. And it's very important to see your ophthalmologist because we want to catch it early, because then we can communicate with your primary care doctor and your endocrinologist and let them know what we see. Now, the reason why that's important is because the eyes are an end organ. What does that mean? That means all the blood vessels, the veins and the arteries come together. And those organs where that happens are end organs. So it may be hard for your endocrinologist to know, or your primary care doctor to know what's going on in the kidney without invasive tests. But since the eye is an end organ, the kidney is an end organ, your heart is an end organ, even your brain is an end organ, I can look in the back and I could say, I see some changes here. They're mild, but that means we may need to do some things. So that means that maybe that same process is going on in your kidneys. And it might be so subtle that it doesn't even change on your labs yet. And if your doctor tells you this, then it's time for you to do something too. Because what I like to do with my patients and let them know it's a partnership. I'm going to give you suggestions, but I need you to take some initiative too and do some things. Be careful of what we put in our bodies. So this is non-proliferative diabetes, but much worse. So you can see their heart exudates. What is that? Well, that is fat leaking out of the blood vessels. We call it lipid, but it's fat, like oils. And we have these blot hemorrhages here. That's actually bleeding in the layers of the retina. So we have to be very careful. And you can see this is in this person, this is happening in the center. This is the macula in the center. It's not, well, even right there, even in the very center. So this person is probably having some visual issues. And we see things like microaneurysms. And when you come to the ophthalmologist, sometimes what they may have to do is do a test called a fluorescein angiogram. And what we do is we inject dye into your blood vessels. It's very safe. It's a vegetable dye, and it allows us to it lights up the blood vessels so we can easily see exactly where the bleeding and where these out pouches are. Now, this area, this dark area, we don't want anything there. That is the fovea area here. So we like that. We like the way this looks, but you see it's encroaching. So just letting you know, I'm trying to show you all the types of pictures that your ophthalmologist may need to do. Now, again, we talked about the macula, which is the center part. We also do a test called an OCT. It's almost sort of like a CT scan. And this is what it looks like normally. And you can see the different layers of the retina. Well, look here. You can see this, it's supposed to have that indentation. But look here, we have a hill and we have some fluid. Now, if I were just to look just with my eyes, it would be hard for me to tell if that's swollen. But when I get the OCT, it's very clear that it is swollen. And I know this person isn't going to see as well as they should. And unfortunately, it is affecting the macula. This is affecting the part of the eye where they see the sharpest. This indentation is where you see the sharpest. Now, we're going to talk about proliferative diabetic retinopathy. And what you see here, you saw what the normal retina looks like. And you see all these little lacy vessels here? These little lacy vessels. They shouldn't be there. What happens is in diabetic retinopathy, because the blood vessels are not normal and they're not able to do the job the way they should, the retina, which is right here, sends out signals saying, hey, I'm hungry. I'm not getting my nutrition that I need to get from the blood vessels. I'm hungry. Make new blood vessels. I'm hungry. I want to be fed and get my nutrition. So what the body does is say, okay, I'm going to make some new blood vessels. Now, the blood vessels aren't made at the time when they should, when we're in the womb. Instead, they're made now, and they're not the right kind of vessels. And they're very sick, they're thin, and they bleed easily. So here again, you can see this is a better picture of these lacy vessels. And then we can also see these lacy vessels when we look, and this is an FA, a fluorescein angiogram. And we can see they're growing right on the optic nerve, which is not good. We can get it other places as well. And you can see these little lacy vessels. They can grow anywhere. So what happens with these vessels? Well, again, they're very delicate. They're not healthy vessels. They're not strong. So they bleed. And you can see this is bleeding in the layers of the retina. And you can see this blood is obscuring the macula. So this person cannot see. What else can happen? You can get a vitreous hemorrhage where it bleeds actually into the vitreous. And again, this person will not see as well. They may see like dark spots floating back and forth. And then if the vessels continue and they're not treated, you can actually get a retina detachment. And if the retina is detached, what does that mean? It comes off, the retina comes off of the sclera where it's supposed to be attached. It's like if you have your bed, you make your bed, and the bedspread is nice and flat on there. Well, if you pull that bedspread off the bed, that's like a retinal detachment. And then you can get new blood vessels other places where they should not be. In the iris, on the front of the eye. In addition, people with diabetes are likely to get cataracts earlier. So you have to see your ophthalmologist, because it could be that you have a vitreous hemorrhage is why you're not seeing well. It could be you have a cataract. We don't know, but you don't know. But once you come to see us, we can let you know what is going on. So how do we treat this? I know it may sound scary, but remember, you can control this. And what we need, studies have shown that tight control of glucose is best. So we don't want your blood sugar going from 300 to 100 and up and down like that. Your hemoglobin A1C is actually a measure of your glucose over the past 3 months. So we like to keep it between 6, closer to 6, but no higher than 7. So if it's high like that, if it's high like 7, 8, 11, you gotta work with your doctor. And studies have shown that exercise really does make a difference. Even if it's walking, you don't have to do, lifting weights like Arnold Schwarzenegger. Just simple walking is good. And that's good for controlling your blood pressure. And even though we like to eat all the sweets, and I love chocolate cake and bread and butter and croissants, all that stuff I like, but I know I can't do it. And you're able to do it sometimes a little more if you're younger, in your 20s, but you don't want to continue to do that. And you want to be careful with your children, because if you let your kids eat all that stuff, all that bad food, they're going to develop more fat cells, and that's going to put them at risk for diabetes. And unfortunately, we're now starting to see diabetic retinopathy in kids, because the kids aren't getting as much exercise and the food they're eating. So the other way of treating this is with laser. Sometimes we have to do laser. And remember I said that the retina isn't getting enough nutrients and oxygen, so it sends out these signals. Well, what we do with the laser is we destroy the outer parts of the retina, way out in the periphery. And that causes, that helps to reduce the signals or the proteins that the retina is sending out to, say, make new blood vessels. And we can do it around the outside, or called pan-retinal, or we can do it focal, different types. This is what pan-retinal looks like. And you see all these squares of these dots. These are laser treatments. Now, what will happen eventually is that these will darken and turn dark. But this is the part we want to save. So all this laser out here, it doesn't really affect the vision. Doesn't affect the vision because it's your peripheral vision. And sometimes we have to sacrifice. Looks like this is where they had the retinopathy, the new blood vessels growing. Sometimes we have to sacrifice the peripheral vision to save the central vision. Now, this may sound a little scary, but it's done in a controlled way. Sometimes we have to put an injection directly into your eye. If your doctor says you need that, we don't take it lightly. I know people are used to hearing, cross my heart, hope to die, stick a needle in my eye. Yes, sometimes we have to do that. And that's why I'm saying prevention is so much better. If you cannot drink the sodas, even just cutting out sodas will make a huge, huge difference. But yes, sometimes we place these injections to kind of maybe take the place of laser or work in conjunction with lasers. Other times we have to, if somebody has the bleeding, the vitreous hemorrhage I showed you, we may need to go in and remove that. So this is removing all of the vitreous, and then it allows us to see what's going on. And everything is very cool these days. We use these micro instruments, it's fiber optic and all kind of things. And it allows us to see the retina, because when all that blood is in there, we can't see the retina either. We can see as good in as you can see out. So this person has a vitreous hemorrhage. You can see they can't see through that, but then afterwards we can say, oh, I can see what's going on. There's some issues here, there's some blood vessels, some bleeding here. I can see what's going on. And that's great. It allows us to treat you. So in summary, it's important to have annual follow-ups. And when you have diabetic retinopathy, it's not your vision insurance that is used. And the reason why this is coming up is because sometimes people think, oh, I don't want to use my insurance up. I can only get one exam. No, with your insurance, you should be able to be seen by the ophthalmologist as often as needed. And this is minimum. Okay. If you're normally, you should be seen once a year. If it's mild, once a year. Sometimes if I'm concerned with the patient, I may go every 6 months. Moderate, at least every 6 months. Severe, it may be more, and your ophthalmologist will let you know. But if they say you need to come back, they're trying to save your vision. So now I'd like to talk about hypertensive retinopathy. What does that mean? If you have high blood pressure, that can affect your eyes too. Now, most people know about diabetes, but I think that hypertensive retinopathy is even more insidious because we don't talk about it as much. So what are the risk factors? Well, there's some that we can do something about, and there's some, hey, we got to play the hand we're dealt, right? So the ones that we can't do anything about, we can't change our family history. You know, it's good to progress in age. And if you have diabetes and kidney disease, well, you have to deal with that. But what can we change? Well, look, salt intake. You gotta change your tongue. If you're used to eating a lot of salt, you like a lot of salt, you gotta change it. It's just not good for you. All of the Coca-Colas and the Pepsis, all of that, all the cakes and stuff. It tastes good, but it's not good for us. If you're not eating enough fruits and vegetables, smoking, we talked about that. Alcohol is bad for diabetes too. If you have diabetes, alcohol, I don't care if it's wine, beer, brown liquor, white liquor, I don't care. All it is sugar water to your body. It's just, you may as well just take a couple of heaping tablespoons of sugar, put it in some water. That's what alcohol is. So it's not necessarily your friend. If you are overweight, I know some of us, you know, the body positivity and all of that, I agree with that. But your body is got to say, hey, if this is too much weight for me and I'm not doing well, it's just the way it is. It doesn't matter if you're body positive, body negative, whatever. Your body's going to tell you what's going on. And having physical inactivity isn't good for us. Our bodies were made to move. So we just talked about this. So let's go over some of the changes. Let me go back, sorry. Okay, so they're very similar to diabetes. You can get the lipids, the hard exudates, you can get the bleeding, and what we usually see, which when we're looking makes us think that it's more high blood pressure, we get these little cotton wool spots. These are fluffy compared to the hard exudates. And these fluffy areas are areas of ischemia, meaning those parts of the retina aren't getting enough oxygen. So it's almost like you're choking off part of that. And what I like to tell people is that, again, if this is happening here, you know, the retina is an extension of the brain. Perhaps this is happening in the brain as well. And then we also can look at the blood vessels, and you see this artery here, it almost looks like a copper wire. That means it's too constricted because your blood pressure is too high. Or sometimes it can look kind of silver or almost whitish. So that's what we're looking at. This is something that's an emergency. If we look and we see swelling of the optic nerve here, that's a medical emergency. That's called malignant hypertension. Malignant, it doesn't mean that you have cancer or anything in the eye. Malignant, it's just meaning that it is serious and it's an emergency. And we don't want you to have a stroke. That's what it means. You could be at risk for stroke. So if this is just like this, there's a poor prognosis for your general health, meaning your life. So what are some of the symptoms? of this, you may have blurred vision, you may be getting a lot of headaches. And a lot of us, oh my God, we're working so hard and everything is so expensive and we're working and we're afraid to lose our jobs. We just pop the Tylenol or whatever it is you take for a headache. But if you're having headaches, please go see your primary care doctor and or your ophthalmologist. I like to tell people, if your body is in pain anywhere, I don't care if it's your foot or your ear, whatever it is, that's your body talking to you saying, hey, I'm not doing well, take care of me. Because you should not be aware of any part of your body. So now we're going to talk about what happens in the veins. And again, the risk factors, as we increase in age, of course, if you have high blood pressure, we have to check your cholesterol, diabetes, and even if you have glaucoma, other problems. So what happens with the vein? Well, it's when something is going through the vein and it clogs it up. It's just like if you have a hose and you stop your hose, like your water when you're gardening and you stop it, what's going to happen? It's going to swell. It's the same thing. And it can happen in one of the central veins or branch veins. So again, what do you see? You might see painless loss of vision. You might notice decreased central vision. I diagnosed someone during a health fair. He said, yeah, there's this little spot in the center of my vision that I don't see so well, but everything else I see fine. It's not a big deal. I had him come to my office. Turns out he had a retinal vein occlusion. Sometimes the vision loss can be very bad. Sometimes you can get intraocular pressure increase, which is different from your blood pressure. And I'll show you what this looks like in the back. So what can happen if it occurs in the central vein, which should be right here, is, again, it's like you have your garden hose. If you squeeze it, what's going to happen? Well, it's going to eventually, the garden hose is going to start leaking because all that water is coming and the water has to go somewhere. It's not going where it's supposed to. So you're going to get little leaks. And these are the leaks. The blood is supposed to go through the veins, but it goes all out through the retina. It can happen in a small area. This is a vein. So it's not throughout the whole retina, just partially, but it did affect the macula. So this affected the superior, and we could see exactly where it is when we do this fluorescein angiogram. We treat it with laser, those intravitreal injections, and they're different types, but that's generally the way we treat it. And the most important treatment is to get your blood pressure down. Now, the same thing can happen in arteries, and it can happen if you have atherosclerosis, meaning you have high cholesterol. And the reason why these are so important, these are generally really strokes in the eye, okay? Which is the same as like either having a heart attack or a stroke, which is a stroke in your brain, or a brain attack as they call it now. So when I tell people who have this, I say, listen, this is your body's early warning system. An early warning system that if we don't get things fixed, you can either have a stroke or heart attack. Right now, it just happened in your eye, which is unfortunate, but you have the other eye and we can try to keep things going. Sometimes we can get the vision back. Sometimes we can't, but it's an early warning system to save your life. And you can see, remember I showed you the other areas, and they were white areas of the retina that wasn't getting enough oxygen. Well, here, the whole retina is white. So that's the problem. And this is what it looks like if it happens just in a small area. The retinal artery occlusion, like I said, is an emergency because it causes irreversible vision loss. Once this happens, there's some things we can try, but really, we're not really successful. Even if it happens in a hospital, we're not successful. And we do the same thing that we do for general strokes. We give thrombolytics. We have people almost breathe a mixture of oxygen and carbon dioxide to help improve oxygen delivery, and we try to lower the pressure in the eye. The same, because these are all vascular problems, the same thing. Just stop smoking. I tell my patients, get a big old mayonnaise jar or save it. And whenever you're paying that $20 or however much it costs for cigarettes, instead just put it in the mayonnaise jar. And I bet in a year, you'll be able to go on a nice vacation. So when these happen, we may see you every 3 or 4 weeks. We first are going to have you see your primary care doctor to make sure that your systemic problem is controlled. So I hope that was helpful. I'm ready to take questions. I'm going to stop sharing.
And Dr. Bovell, we can't thank you enough for giving us an excellent review of the anatomy of the eye and disease of the eye. I can't tell you how clear you made something that most people would be very afraid to even try to tackle.
Well, I'm very passionate about this, and especially the things that we can do to help. But sometimes it's difficult, and it's even difficult for me. I mean, I'll tell you, I love the chocolate cake. I have to tell myself, try not to eat it. And you know what? Thank God we get a new day every day. If you don't do well this day, we have another day to try to do better.
That is so true. I'm going to start the questions off, and then I'm going to turn it over to my co-moderators to share their questions with you. And then we have a couple of good questions in the chat.
Sure.
So my question to you is, you very eloquently discussed the importance of tight glucose control in the management of diabetes and diabetic eye disease. Has there been enough time now for us to have information on either risk or concerns for people who have diabetes and who are taking Ozempic?
I don't know if there's been any studies on Ozempic and
that
diabetic
class.
eye disease. Sure. I can look that up and I'll get back to you on that. But anything that helps to control the blood sugar is good. Whether it's Ozempic or Wegovy or exercise or metformin, anything that helps to control the blood sugar is good.
Dr. Walks, the floor is yours.
Thank you, Dr. Neighbor Stevens. Thank you, Dr. Bovell. That really was very, very useful, very easy to understand. My question is, if you're doing many of the right things, are there other opportunities via either vitamins or certain kinds of food? We've always heard that carrots are good for the eyes, that kind of thing.
Sure. I always tell people, your grandmother was right. Eat your carrots, eat your vegetables, eat the rainbow. Yes, indeed. The zeaxanthins, the colored vegetables like red cabbage and the darker vegetables, blueberries, all of those things, the skin of the apples, all of that is good and helps the retina. Yes.
Thank you.
Dr. Hines, you have the floor.
Thank you again. I learned several things in that presentation too to help me remember some of the differences in the different types of eye disease. But my question was more kind of geared towards our viewing population, in the sense of, we talk a lot about health disparities and that oftentimes Black people aren't getting the aggressive treatment options, and I'm being general. There's a lot of watchful waiting kind of things that often happen in the ophthalmology space.
Mhm.
How can our patients kind of know how to advocate for themselves to make sure that they're getting, some of the appropriate treatments that you're discussing? Because sometimes, especially in too many cases, in diabetes in particular, we, in general, are a little slow to move sometimes.
Yeah, well, yeah, I'm really glad you brought that up, because the health disparities, anything that is a barrier to getting any kind of care, social determinants of health, the food deserts we talked about. I'm telling you to eat the rainbow, and if you don't have a car and there's not a grocery store near you or within walking distance, then that's hard. And maybe all you can do is go to the corner 7-Eleven or whatever it is, and they don't always have the best foods and things. So yes, indeed, that is an issue. So that is hard, the barriers to care, because how do we solve that? And even if I tell my patients you should be walking, well, they live now, and I'm in DC, and I'll tell you, it's bad all over. I mean, people are getting carjacked here, there, everywhere, and you don't feel safe walking. What are you supposed to do? So yeah, that is an issue. I also tell my patients, and this goes for me too, if you live in a city, generally there are a lot of ophthalmologists. If you feel that you are not being treated properly, it is okay to change your ophthalmologist. It is, or any doctor, if you feel you're not being treated properly. And because you're the only body that you have. So you have to do what's best for your body, but sometimes you don't even know. So what I try to do with my patients is give them enough information. I try to give them pamphlets and things to take home, because it's hard to remember. You're talking and people are telling you scary things, and inside you're nervous. Am I gonna go blind? What is she saying? And you might not hear everything that I'm saying. You may want to take notes. You may want to say, when I come back, I'd like to ask questions. Sometimes if you feel that the doctor is putting you off, like they're saying, oh, you have a little touch of diabetic retinopathy, but we'll see you next year. You can say, well, I'm concerned about that. I'd like to be seen sooner. And then you can say, hey, can you, it's really windy here, sorry. You could say, can you send a letter to my primary care doctor, so that then you can talk to your primary care doctor, and maybe your primary care doctor might be able to help get a second opinion.
Thank you.
That's a great question.
There was a question in the chat asking, can you see retina and optic nerve changes in patients with Alzheimer's?
Oh, sure. You can see it in anybody who has an eye. Yes, you can. You can see diabetic changes in Alzheimer patients. All we have to do, sometimes it's a little hard for the Alzheimer patients maybe to stay still, but if we dilate their eye well, and they can maybe look at a camera, and we can say, look at that camera, we can get a quick picture, that will help us. And I will tell you this, with people who have dementia or Alzheimer's, if they aren't seeing well, that can make the dementia or Alzheimer's worse. One of my dear friends was concerned about her mom, and we just talking. She said her mom was declining. She doesn't do much anymore. All she does is sit and listen to the radio. And before, she used to be out and active and doing things. And I asked her, I said, well, how old is your mom? And she told me she was in her 80s, I think. And I said, has she ever had cataract surgery? She said, no. And I said, your mom probably has cataracts. Why don't you take her to an ophthalmologist so she can get her cataracts removed? Her mom got the cataracts removed. She couldn't see. So she was able to see, she was able to engage with her daughter again. And her mom did fine afterwards. I mean, just imagine if you couldn't see anymore, you can't watch TV, you don't know what's going on, you're not happy talking and interacting, you don't want to go out, so your world becomes smaller. So that can help a lot.
Dr. Walks, is there anything else we need to address? You are muted.
Sorry. There was another question in the chat with regards to, I think, smoking in general. Dr. Bovell, you were very clear. This question is more related to, is marijuana smoking a different risk than cigarette smoking?
If I had $1 every time someone asked me that, I'd be out on the beach somewhere. Okay, so smoke is smoke. Okay, it's a foreign substance going into your lungs, and then what happens is the lungs are connected to the blood vessels. Then it can transfer from the blood vessels into your bloodstream. So any kind of substance, I don't care what it is, the only thing that should go into your lungs is fresh air. That's it. So, and let me set aside, since you mentioned this, people always say, I have glaucoma, can I smoke marijuana? Studies have shown that it's not helpful. Once the marijuana is metabolized, it's metabolized into something called a prostaglandin. And that helps to lower blood pressure. Well, we have prostaglandin eye drops that don't have all of those side effects. Second, I mean, I guess most people are getting the marijuana from the dispensaries, so it's not, you know what you're getting, I suppose, as opposed to getting it from the street where we know you don't know where you're getting, and it could have fentanyl and everything else, and you could die. But the other thing is sometimes the marijuana can paradoxically cause the pressure to go up. And because we don't know exactly what's in it, even if you know, like, I want this kind of marijuana from the dispensary, that kind, there haven't been studies that show which kinds work on the eye. And then it only lasts for a couple of hours. So that means you have to constantly be smoking, and constantly smoking isn't good for you, because I don't know if people remember this, but what was one of the syndrome? I hope I'm not offending anybody by telling this, but I'm just saying the facts. That, remember what they used to say about marijuana? You get the gunners. That's what they told you, the gunners. What is the gunners? It's a decreased motivation syndrome. So you just kind of sit around and you say, oh yeah, I should do that. Yeah, I should do that. So you don't have your motivation to fully actualize yourself.
I'm so glad that we had that question in the chat, because I certainly have heard from several people that they're using their marijuana to treat their glaucoma. So I'm glad.
There is no study that supports that.
I want to, while Dr. Hines is checking the chat, I want to raise a question.
Can I say one more thing? I'm sorry, Dr. Stephen. People think, oh, I want to do this natural. I want natural, but that's not natural for your body. I just want to say that.
Yeah, very excellent point. I want to ask you, related to what I've highlighted in your intro, your background in cybersecurity. I want to ask the question, given the very large incident that occurred, but not the first for sure, but the very large incident that happened this week with Chance and health information, what should our audience be concerned about? I mean, we're moving rapidly toward utilization of telehealth. All physicians, well, many physicians are moving toward portals for their patients to use to communicate and to see their records. What words of either encouragement or preparation and prevention can you share with our audience regarding the world we live in, which is
Sure.
we got cybersecurity
Yeah.
issues?
Well, yeah, the Change Healthcare, that's been huge. It's affected people getting their medications, sometimes getting the pharmacies can't communicate, even getting treatment, because we have to do these things. The audience may be aware of prior authorizations. That's when they want the doctor to send a letter and beg the insurance companies to let us treat you either with medicine or getting a CT scan or whatever else it may be. So it's affecting treatment. So probably one of the best things to do is you can assume that your healthcare data, or not your healthcare data, but your passwords may have been breached. And there are certain sites you can go to. You can just Google, has my data been breached? And there's certain sites you can put in your email and it'll tell you if it's been breached. I would advise everyone to definitely use VPNs, definitely use antiviral software. And when you go to the coffee shops and to the airports, don't use their Wi-Fi, because people are on that Wi-Fi trying to sneak and pretend and get your information. So what I do is your cell phones can have be used as a mobile device, and at least you know what that is. In addition, what you should do is you can, yes, VPNs, somebody said that. Yes, VPNs, that's exactly correct. Because what the VPNs do is it as your data is going across, it's encrypted, meaning it's like secret. So as it's traveling across, it's like if I'm driving from here, from DC to New York, people can't see me driving. But then once I get there, people are like, oh, it's Dr. Bovell. And they can, because they have the password to open it. So that's very important. The other thing which what you can do is you can call your credit card companies, and it's sort of like putting a freeze on your credit, which means that, when you go to, I don't know, Macy's, and they're always asking you to open a credit card, and you give all your information. Well, instead of that, if you want to give someone your information, then you have to use a password. People can't just all of a sudden look and get into your credit information without your permission. And sometimes almost like behind your back. So you can freeze that so that people can't do that. And I would say, if you're concerned, change your passwords. Try not to use the same password, although it's very, very difficult. Don't use, like, sometimes people use their birthday. Don't use your birthday. Sometimes it's a good idea to use a password that has like a lot of numbers. Like you can say, you can make a password and you can write it out like 1 + 2 = 3. But sometimes what I do is I won't say 1 + 2 = 3. I might say 1 + 2 = 10, right? Because no one's going to guess that. and I may like spell out the number 1. I may use the plus sign, and then I may use the equal sign, and then I may use 10, the number 10, or spell out 10, something like that. But something that you know that you'll remember. And if you're concerned, call your credit card companies and let them know that you're concerned as well. And look at your credit card data. And with your healthcare, look at when you get the EOBs back, look and make sure. They did a segment several years ago on 60 Minutes, and this one person, they said she had a prosthetic leg. And she had 2 good working legs, but somebody had gotten a hold of her insurance, was billing her insurance for a prosthetic leg because they cost a lot of money.
Dr. Hines, is there anything that we need to follow up on in the chat?
No, there are no new questions in the chat, but just a clarification that EOB is that explanation of benefit statement that often you will get from your insurance provider.
Yes, thank you.
The one that
It's
often says, this is
mailed
not
to
a bill, right? It says, this is not a bill. It looks like a bill. It's got dollar signs and what you may owe, but this is not a bill. That's always the trigger.
Yes, yes.
Well, this has been such an informative session today. We want to thank you for coming back and helping us to understand how and why we should take better care of our eyes and help us out with all this cybersecurity. I'd like to ask my co-moderators for their last comments, but before we do that, we have a little bit of business we need to do. We are in the process of creating a new mailing list, and I'm going to ask our producer to please explain what we need to ask everyone to do. Simon?
Good afternoon, everybody. I put a link in the chat. At the very last link, it says follow this link to fill out the form. Click on that, fill it out, submit it. That'll guarantee that your email address will be on this new mailing list. That'll be our permanent one going forward.
Thank you, Simon. And Simon, thank you for all your help and all the ways that you help us.
My pleasure.
Dr. Hines, closing comments? Well, I'm sorry, Dr. Hines, before I give you that, Dr. Boville, any closing comments?
No, I would just like to say, I really appreciate this. I think, the Black Health Trust is doing such a good job to help to educate our community, and hopefully, people will find this beneficial. And I just appreciate what you're doing. And I just like to encourage people to try, if you can. It's sometimes difficult and it may be intimidating, to talk with your doctors, but just try to find a doctor that you feel comfortable with. So, because you're sharing about your body, your innermost secrets there. So try to find someone that you're comfortable with.
All right, now, Dr. Hines.
Thank you. And thank you, Dr. Boville, for a very clear presentation with some very real life examples of things that these treatments can do and what the potential consequences are, because there's a lot of words out there, and we're talking about the retinal diseases, and it can be a little hard to understand. One of the other things that I think that was really pointed that you shared is also the importance and the ability for people to get a second opinion, right? If you feel like you're not getting the right care, you're not sure. You made 2 really helpful statements. As one, and this happens often, the importance of a primary care provider and how sometimes your primary care provider can be that advocate for you if you're not sure, or sometimes you might need to get a second opinion if you don't either feel comfortable or you're not sure that you're getting the care that you need. So those are really, in addition to the general topic, those are also things that we can transfer to the rest of our medical healthcare thoughts too. Thank you again.
Dr. Walks.
Dr. Boville, thank you. I'll add my thanks to everyone else's. As someone who has had these glasses on my face since I was 7 years old. I think a lot about being able to see. And sometimes I'll just close my eyes and just think about how different life would be if I couldn't see. And so you and your colleagues and all of those who help get the message out that good eyesight is not guaranteed. And sometimes you can't just go and get some new glasses and make it all better. And so this notion about protecting the eye health that we have is very important. And also one of the things I liked that you did was really connecting that to the other parts of our body, those other end organs that can help us understand that, hey, whatever you're doing, stuff is starting to break down. And there are things that you can do ahead of time to preserve it. And then the whole prevention and early intervention beats everything else. All the fancy things we discover, all the interventions we have, prevention and early intervention beat all of those. So thank you so much.
And I would like to close again, thanking you for spending a little time with us today and asking if you would consider returning, because there's a lot of things that we have yet to touch on that impact our community, both our children and their eye health, as well as adults. So hopefully you will find some time and can come back and spend a little more time with us in the future.
I would love to.
Thank you. And with that, I'm going to wish all of you a very good rest of the day. And we look forward to seeing you again next week here on Black Health Trust. Thank you and bye-bye.
Good day, everyone.